Welcome to COVID-19 Essentials. My name is Myke Kudlas, and I am the Associate Executive Director at the American Society of Radiologic Technologists. This short presentation will provide radiologic technologists and students with some basic information about the current COVID-19 pandemic. We are going to be looking at what COVID-19 is, what we currently know about the disease process, and how we as healthcare providers can respond in order to protect ourselves and the general public while providing excellent care to our patients. COVID-19 is the disease caused by a novel virus called the Severe Acute Respiratory Syndrome Coronavirus 2, or SARS Coronavirus 2. The term novel when discussing the coronavirus simply indicates that this is a new virus that has not been previously identified. The disease was named COVID-19 on February 11, 2020 by the World Health Organization. In the disease name, CO stands for corona, VI for virus, D stands for disease, and 19 indicates the year of the disease's discovery. Coronaviruses get their name for the crown-like halo of spikes on the virus's surface. You have likely seen a rendered image of a coronavirus on news reports or on the internet and noticed their spiked surfaces. Corona is a Latin word that means crown, garland, or wreath. We hear other forms of this Latin word in other contexts. For example, in English, we call it a coronation when a king or queen is crowned for the first time. During a solar eclipse, it is possible to see the crown-like corona of the sun, which is the outermost region of its atmosphere consisting of hot ionized gas. And yes, the next time you look at the label of a Corona beer, you will see a prominent image of a golden crown for which the brand is named. Although COVID-19 is a new disease, there are other well-known viruses that also have the characteristic coronavirus feature. There are 7 known coronaviruses that cause infections in humans, some of which you may have already heard of. They include 229E, NL63, OC43, and HKU1. These are common viral infections that occur around the world. Other less common coronaviruses are MERS coronavirus, which is the coronavirus that causes Middle East Respiratory Syndrome, or MERS, and SARS coronavirus, the coronavirus that causes Severe Acute Respiratory Syndrome, or SARS. SARS coronavirus 2, which causes COVID-19, is the 7th known coronavirus that can cause infections in humans. Sometimes diseases that infect animals can also cross the species barrier to infect humans. Diseases that have their origins in animals are referred to as zoonotic diseases, or zoonoses. Coronaviruses are zoonoses, and depending on the individual virus, may be transmitted by different species of animals. Middle East Respiratory Syndrome coronavirus, for example, is transmitted to humans from dromedary camels, and the Severe Acute Respiratory Syndrome is spread from different species of birds in Southeast Asia. The exact source of COVID-19 is currently unknown, but both MERS coronavirus and SARS coronavirus had their origins in bats, so that is a likely source for this virus. Although the virus can cross some species barriers, it is unlikely that anyone in the United States is at substantial risk of catching COVID-19 from pets or farm animals. In some cases, dogs and cats have tested positive for COVID-19 after contact with infected humans, and ferrets also appear to be susceptible to the infection. However, there's no evidence that these animals can transmit the disease back to humans. In general, it's always a good idea to practice basic hygiene when interacting with animals, especially unfamiliar ones. The virus that causes COVID-19 is thought to spread mainly from person to person. especially between people who are in close contact with one another, specifically 6 feet or less. COVID-19 is a respiratory disease, so it primarily is transmitted through respiratory droplets ejected when an infected person coughs, sneezes, or talks. These droplets carry the virus and infect others when they are inhaled or land on the exposed mucous membranes of nearby people, such as the eyes, nose, or the mouth. It is not yet known whether other body fluids can transmit COVID-19. Transmission rates to humans from surfaces contaminated with the virus are not certain, although some studies indicate that the virus may remain viable for hours to days on some surfaces. According to the World Health Organization, or WHO, the COVID-19 virus can survive up to 3 days on plastic and stainless steel, less than a day on cardboard, and about 4 hours on copper. It is also unknown how long the air inside a room occupied by somebody with confirmed COVID-19 remains potentially infectious. Increasing ventilation to the exterior of the building can reduce the potential infection risk of airborne viruses in enclosed spaces. Because COVID-19 is a new disease, there is limited information about risk factors for severe forms of the disease. Currently available data indicates that those aged 65 or older, or living in a nursing home or long-term care facility, are at greater risk. Anyone with an underlying medical condition is also susceptible, including people with chronic lung disease, moderate to severe asthma, serious heart conditions, or people who are immunocompromised. Many factors can suppress an individual's immune system, including cancer treatment, smoking, bone marrow or organ transplantation, poorly controlled HIV or AIDS, and prolonged use of corticosteroids. Other known risk factors include severe obesity, diabetes, chronic kidney disease, and liver disease. According to the Centers for Disease Control, or CDC, symptoms of COVID-19 appear 2 to 14 days after initial exposure to the virus. Patients with COVID-19 report symptoms ranging from mild to severe. These symptoms include fever or chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, and diarrhea. The most common symptoms of COVID-19 are fever, cough, and fatigue. Several studies have documented COVID-19 infection in patients who never develop symptoms or whose symptoms have not yet occurred. Because asymptomatic people are rarely tested, the rate of pre-symptomatic or asymptomatic infection is not well understood. In limited studies that have been conducted, the rate of asymptomatic patients ranges from 13% to 15% of all infections. It is important to note, however, that these are early studies, and the transmission of COVID-19 through asymptomatic infection is not confirmed. In a study of more than 44,000 people with COVID-19 in China, 81% of patients had mild to moderate symptoms, 14% displayed severe symptoms, and 5% had symptoms that were categorized as critical. In this same study, the overall fatality rate was 2.3%, although the fatality rate among patients with critical symptoms was 49%. In the U.S., the percentage of infected persons hospitalized with COVID-19 is roughly 19% of all infections, with 6% of all infected persons admitted to the intensive care unit. Diagnosis of COVID-19 is accomplished through viral testing and the detection of the SARS coronavirus 2 RNA, usually in nasopharynx swab samples. SARS coronavirus 2 RNA has also been detected in stool and blood. Detection in the blood may indicate severe illness. Lymphopenia, or reduced levels of lymphocytes, is the most common lab finding in coronavirus patients and is found in as many as 83% of hospitalized patients. Chest radiographs of patients with COVID-19 are generally unremarkable early in the disease, but later demonstrate bilateral airspace consolidation. Chest CT images from patients with COVID-19 typically demonstrate bilateral peripheral ground glass opacities. The American College of Radiology does not recommend CT screening as the only test for diagnosis of COVID-19 due to the variability in chest imaging findings for radiography or CT alone. Patients with mild symptoms may not require hospitalization and should be able to manage their illness at home. The decision to monitor a patient in an inpatient or outpatient basis depends on the clinical presentation, requirement of supportive care, potential risk factors for severe disease, and the ability of the patient to self-isolate at home. Patients with severe disease require hospitalization. Inpatient treatment revolves around supportive management of the most common complications of severe COVID-19, including pneumonia, respiratory failure, sepsis, cardiac arrhythmia, and acute kidney injury. There are also reports of hospitalized patients demonstrating thrombotic complications, most frequently deep vein thromboses and pulmonary embolism. No vaccine for the COVID-19 virus is currently available, but several vaccine trials are in progress. The National Institutes of Health have published guidelines for the medical management of COVID-19 patients, but these guidelines are designed to manage the symptoms, not cure the disease. No FDA-approved drugs have demonstrated safety and efficacy in randomized controlled trials when used to treat patients with COVID-19, although the FDA has granted emergency use authorization for the use of remdesivir to treat severe cases. Any investigational therapies for the treatment of COVID-19 should be included as part of a randomized controlled trial so that beneficial drugs can be identified. Unproven or unapproved medications should not be included as part of non-study COVID-19 management. Because COVID-19 is caused by a virus, antibiotics are not effective for prevention or treatment of COVID-19. In hospitals, some physicians may use antibiotics to treat secondary bacterial infections, which may be complications of COVID-19 in severely ill patients. COVID-19, like almost every other infectious disease process, is reliant on the chain of infection to sustain itself. Each link in the chain connects consecutively to transmit infection from one person to another. In order for a new infection to occur, there must be a complete chain of infection. The chain of infection begins with a disease process, in this case, the COVID-19 virus. The virus needs a reservoir in which to live and reproduce. The human body is a common reservoir because it is warm, has a constant temperature, and has several viable portals for entry and exit. In the case of COVID-19, the respiratory system, specifically the nose and the mouth, are the primary portal of exit. After exiting the reservoir, the infectious agent requires a mode of transmission. The primary mode of transmission for COVID-19 is suspension of viral particles in respiratory droplets. The next link in the chain of infection is the portal of entry into a new susceptible host. For COVID-19, inhalation into the lungs or respiratory droplets passing through the mucous membranes of the nose and mouth are the primary portals of entry. In order to prevent the transmission of infection, one or more links in the chain of infection must be broken. For many infectious agents, the chain of infection is easily broken at the mode of transmission link through hand washing, surface cleaning, and covering coughs and sneezes. When a pathogen is more infectious, like COVID-19, however, additional steps may be needed to break the mode of transmission link, such as wearing a mask, washing hands more thoroughly and frequently, and using alcohol-based hand rubs. Wearing a cloth face covering can also help to break the portal of exit link, and in some cases, the portal of entry link. The reservoir link can be broken through social distancing from infected individuals, as well as by simply staying in isolation at home. A quarantine is a more extreme way to ensure that reservoirs or potential reservoirs do not continue the chain of infection. Vaccines, antibodies, or immunity are the only ways to break the infectious agent link in the chain of infection. Many medical facilities have already taken multiple steps to reduce the overall risk of infection by limiting the number of people in the building. Some other steps include canceling elective procedures, using telemedicine, limiting the points of entry, and screening everyone entering the facility for any COVID-19 symptoms. Additional steps to reduce the spread of infection in the healthcare setting are to install barriers between patients and staff, improving ventilation, encouraging patients and visitors to practice hand hygiene, and quickly isolating symptomatic patients by moving them to private rooms with private bathrooms if possible. By now, everyone knows that washing your hands is by far the best way to break the chain of infection and prevent the COVID-19 virus from spreading. There are two methods that can be used for hand hygiene: alcohol-based hand sanitizer and washing with soap and water. Alcohol-based hand rubs are the most effective products for reducing the number of germs on the hands of healthcare providers, and according to the CDC, are the preferred method for cleaning your hands in most clinical situations. Unless your hands are visibly soiled, an alcohol-based hand rub is preferred over soap and water because evidence shows that healthcare workers are more likely to use alcohol-based hand sanitizers compared to soap and water. Hand rubs are generally more convenient to complete and less irritating to your hands. The CDC recommends using alcohol-based hand sanitizers with greater than 60% ethanol or 70% isopropanol alcohol in healthcare settings. When using an alcohol-based hand sanitizer, you should put a generous amount of the product on your hands and begin rubbing your hands together. As you are rubbing your hands, make sure that you cover all surfaces of your hands, including the backs of your hands, the nail beds, and between your fingers. Keep rubbing until they are dry. This should take about 20 seconds to complete. Your hands should be washed with soap and water when they are visibly soiled, before eating, and after using the restroom. They should also be washed immediately before touching a patient, before performing an aseptic task, before or after handling an invasive medical device, and immediately after removing gloves. It is also important to avoid touching your eyes, nose, and mouth with unwashed hands. According to the CDC, when washing your hands with soap and water, first wet your hands with water. Then apply soap to your hands. Rub your hands together vigorously for at least 15 seconds, covering all surfaces of your hands and fingers. WHO recommends washing your hands for 20 seconds, then rinsing your hands with water and using disposable towels to dry them. Use the same towel to turn off the faucet. The water should be warm, but avoid using hot water as it will dry out your skin. In testing, it has been found that infectious agents can survive under artificial decorative fingernails even after using an alcohol-based hand sanitizer or hand washing. The CDC recommends that healthcare providers refrain from wearing artificial fingernails during direct contact with patients, especially those that are at high risk. Keeping natural nail tips to less than a quarter-inch long will also help reduce germs on your hands. Some studies have shown that skin underneath rings have more germs than other areas of the fingers, so rings should be removed to improve hand hygiene. Gloves should be worn in a healthcare setting in accordance with standard precautions when it is reasonable to assume that you will come into contact with blood and other potentially infectious substances, such as mucous membranes, contaminated skin, or contaminated equipment. Hands should be cleaned both prior to putting on gloves and immediately after removing them. Gloves are not a substitute for proper hand hygiene. Immediately change gloves and clean your hands if your gloves become damaged or visibly soiled with blood or body fluids. You should never wear the same pair of gloves when providing care for more than one patient. Reuse of disposable gloves causes cross-contamination between patients and surfaces. Healthcare personnel should follow standard and transmission-based precautions when caring for patients with COVID-19. The CDC recommends using personal protective equipment, or PPE, when providing care to patients with COVID-19, including an isolation gown, an N95 filtering respirator, a face shield or goggles, and gloves. There are several acceptable methods for putting on and taking off PPE. The best source of information is your individual healthcare facility's procedure. However, here is one example of a procedure to put on PPE. First, identify and gather the proper PPE to put on, ensuring that you have access to the correct size of gown, gloves, and mask. Next, clean your hands using hand sanitizer. Then, put on an isolation gown, ensuring that all ties on the gown are tied. You may need to seek the assistance of other healthcare personnel to help with the tying. Next, put on a NIOSH-approved N95 filtering respirator. If the respirator has a piece of metal in the nosepiece, it should be fitted to the nose with both hands. The respirator should fit tightly to your face with no gaps or holes. It should extend under your chin and cover both your mouth and nose. The respirator straps should be placed on the crown of your head and the base of your neck. In some facilities, respirators are only required when a healthcare worker is involved with an aerosol-generating procedure, such as an intubation, airway suction, or bronchoscopy. Otherwise, regular surgical masks can be used. Next, put on a face shield or goggles. Face shields provide protection for your entire face, while goggles provide excellent protection for your eyes. Finally, put on gloves, ensuring that they fit tightly and cover over the cuff of the gown. Now you are prepared to enter the patient's room. To remove PPE, start by removing your gloves. There are several techniques that can be used to remove the gloves, but it is important to not contaminate your hands by touching the outside of the gloves. Next, remove your gown by untying all ties. Some gown ties can simply be broken rather than being untied. Carefully grasp the gown by the shoulders and pull the gown down and away from the body. Then dispose of it in the trash receptacle. Next, clean your hands before removing your face shield or goggles. The face shield or goggles should be removed by grasping the strap and pulling up and away from your head. Do not touch the front of the face shield or goggles. Finally, grasp the respirator by the straps, not the front, and remove and discard it. Now clean your hands again. During the COVID-19 pandemic, many facilities are reusing PPE due to supply shortages. In this case, you may need to follow a special procedure established by your facility. As a part of routine practice, you should monitor yourself for fever and other symptoms of COVID-19. After all, we can't care for patients if we are ill or if we transmit the disease to a coworker. Take your temperature at home before going to work if you suspect that you might have a fever. If you have a fever or feel ill, you should inform your workplace and stay home. Most healthcare facilities are currently screening employees at the beginning of their shift for fever and COVID-19 symptoms. Fever is defined by the CDC as a temperature over 100 degrees Fahrenheit. If you develop a fever or COVID-19 symptoms while at work, you should put on a face covering, inform your supervisor, and go home to monitor your symptoms. If you suspect that you have been exposed to COVID-19 while in the workplace, you should contact your supervisor or employee health department as soon as possible. As the incidence of COVID-19 in the United States has become more widespread, the CDC's recommended response to work-related exposures to COVID-19 infected patients has evolved. The CDC currently advises facilities to implement universal symptom screening and source control strategies. This response allows healthcare facilities to focus on exposures that are believed to put employees at higher risk, such as prolonged exposure to patients with COVID-19 when PPE is not in use, or not having the proper PPE during an aerosol-generating procedure. These types of exposures should be evaluated on a case-by-case basis, and specific actions such as restriction from work can be implemented if there is an increased risk of transmission. During the COVID-19 pandemic, it is essential to continue to protect yourself, your coworkers, and your patients by extending infection control practices to public places and even to your own home. Taking precautions in your private life will reduce the risk of bringing the virus into the healthcare setting and also reduce the risk of you introducing the virus to the public. The four most effective ways to continue infection control in your private life are hand hygiene, cloth face coverings, home cleaning, and distancing. Hand hygiene in public is very similar to the hand hygiene procedures that were previously described in the healthcare setting. You should clean your hands with an alcohol-based hand rub or wash them with soap and water frequently, and especially after touching anything in public. It is important to avoid touching your eyes, mouth, or nose. Glove usage is not widely recommended for the public because cross-contamination from surfaces can quickly contaminate gloves. The CDC recommends wearing disposable gloves only when you are specifically cleaning or disinfecting surfaces or when caring for someone who is sick. In both cases, the gloves should be immediately discarded after use. Wearing gloves outside of these circumstances will not necessarily protect you from getting COVID-19 and may actually lead to the spread of germs. For gloves to be effective, they must be replaced each time you touch a new surface. In the public setting, proper hand hygiene is more reliable and effective than disposable glove use. A cloth face covering does not necessarily ensure the wearer is immune to infection by respiratory droplets, but it helps substantially in keeping the wearer from spreading the virus to others by trapping larger droplets within the fabric. Cloth face coverings provide an extra layer of protection to prevent respiratory droplets from traveling in the air and onto other people. The cloth face coverings recommended by the CDC are not surgical masks or N95 respirators. Those are critical supplies that must continue to be reserved for healthcare workers and other medical first responders in high-risk work environments. To get the most protection from a cloth face mask, it must be used correctly. To put on a cloth mask, first begin by cleaning your hands. Then, holding the straps or elastic of the face covering, place it over your nose and mouth and under your chin, securing it using the straps or elastic behind your ears or tied behind your head. Ensure that the face covering fits snugly against the side of your face to ensure air passes through the covering rather than around it. Last, make sure that you can breathe easily and that the covering is secure. Make sure that you keep the face covering on your face the entire time you're in public. Do not pull it down or aside to breathe or speak, as this also removes its protection. Do not put the covering around your neck or up over your forehead. The covering should remain over your mouth and nose for the entire duration of its use. Do not touch the face covering, and if you do, wash your hands. To remove the face covering, untie the strings behind your head or remove the ear loops. Handle the face covering only by the ear loops and ties, and fold the outside corners together. Be careful not to touch your eyes, nose, and mouth when removing the covering, and clean your hands immediately after removing the mask before touching anything else. Cloth face coverings should be washed after each use as they trap respiratory droplets and may become contaminated with viral particles. There are two main ways to clean cloth face coverings. The easiest and most effective is to include your face covering with your regular laundry. Use regular laundry detergent and the warmest appropriate water setting for the cloth used to make the face covering. You can also wash your face covering by hand by preparing a bleach solution of 5 tablespoons household bleach per gallon of room temperature water. Check the label to see if your bleach is intended for disinfection. Some bleach products, such as those designed for safe use on colored clothing, may not be suitable for disinfection. Soak the face covering in the bleach solution for 5 minutes. Rinse thoroughly with cool or room temperature water. To dry your face covering, use the highest heat setting in the dryer and leave the covering in the dryer until completely dry. You can also air dry your face covering by laying it flat and allowing it to completely dry. If possible, place the face covering in direct sunlight, as the UV radiation will help to sanitize it. At home, you should clean and disinfect frequently touched surfaces daily, including tables, doorknobs, light switches, countertops, desks, keyboards, toilets, and faucets. To clean surfaces, you should wear reusable or disposable gloves for routine cleaning and disinfection, and clean surfaces using soap and water before using a disinfectant. Cleaning with soap and water not only reduces the number of germs, it also reduces dirt and other impurities from the surface. Disinfecting, on the other hand, is performed to kill germs on surfaces. To properly disinfect surfaces, the CDC recommends the use of an EPA-registered household disinfectant. You should follow the instructions on the label to ensure the safe and effective use of the product. Most products recommend keeping the surfaces wet for a specific period of time and using precautions such as wearing gloves and using the product in an area with proper ventilation. Distancing is an important part of breaking the chain of infection during the COVID-19 pandemic because the disease is primarily spread through respiratory droplets. The further you are away from an infected person, the lower your risk of contacting these droplets when the infected person coughs, sneezes, or speaks. Quarantine is used to separate someone who may have been exposed to COVID-19 from others. Quarantine is intended to prevent disease transmission by removing the person from the general population before they are symptomatic. People who are in quarantine must stay home, separate themselves from other people, monitor their own health, and follow any directions their local or state health departments have provided. Isolation is designed to separate people with a known COVID-19 infection from those who are not infected. People who are in isolation must stay home until they have recovered from the disease, and it is safe for them to be in public. Anyone in isolation at home should take the additional step of separating themselves from others that are living in the same home by staying in a dedicated room and using a separate bathroom if possible. Social distancing means keeping a safe physical distance from other people in any other type of social interaction. Could be shopping or dining in a restaurant or even speaking with a neighbor. WHO recommends a social distance of 1 meter, but the CDC recommends staying at least 6 feet apart. Remember that one of the uncertain characteristics of COVID-19 is that people without symptoms may be able to spread the virus, so that is why it's always important to use social distancing. Another component of social distancing is not gathering in large groups and avoiding crowded spaces, especially indoors. A final component of extending infection control practices to public places and your home is to monitor your own health. You should be alert for COVID-19 symptoms, especially fever, cough, and shortness of breath. This is especially important if you find yourself in settings where it is difficult to keep a physical distance of 6 feet from other people. If symptoms do occur, take your temperature to confirm a fever, and keep in mind that your temperature may be elevated for 30 minutes after exercising or may be reduced after taking medications like acetaminophen that can lower your temperature. Finally, let's discuss 3 important concepts and how they apply to the COVID-19 pandemic: diligence, vigilance, and resilience. Diligence is defined as careful and persistent work or effort. The information in this module is only helpful if we are diligent when we apply it. All of this knowledge would not help if we don't follow these principles with every patient in every situation. It is not good enough to practice hand hygiene most of the time, or sometimes wear a mask when performing patient care. We must practice diligence by being careful and persistent, especially when we are in a hurry, or it feels like it's not convenient. Errors occur during times of pressure because we take shortcuts. Vigilance is the act of being watchful, especially to avoid danger. If Diligence is ensuring that we are doing the right thing, Vigilance is ensuring that everyone around us is also doing the right thing. In an emergency, it is easy to forget to follow correct procedures, such as scratch an itch on our face, even without thinking about it. If you see something wrong, let the other person know in a gentle manner. Be alert to infection control practices and ensure the entire team is being careful. We are all in this together, so it is important to keep the team healthy and protect our patients by being on the lookout for mistakes. Just remember to be kind while keeping your colleagues accountable. That leaves one last important word: resilience. The American Psychological Association defines resilience as the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. The current COVID-19 pandemic has definitely challenged our healthcare system and healthcare providers more than probably at any other time in our lives. For me, 2020 marks my 25th year as an RT, and one thing that I have seen over these 25 years is that RTs are resilient, creative problem solvers. We will get through this crisis as a profession, as a team, and as individuals. Resilience means withstanding and bouncing back from these difficult circumstances, but resilience can also lead to profound personal growth. May we all learn from this current crisis to be resilient, to adapt in the face of adversity, and to elevate our personal and professional skills so that when this crisis is over, we are able to provide even better care for our patients. Information about the COVID-19 pandemic is rapidly evolving, as is our response to it. This module was written based on the most recent data available from the CDC, the WHO, and ACR websites that are listed here. For the most up-to-date information, please visit these sites or the website for the health department in your state. Your individual facility likely also has information about their response to COVID-19, and your facility is the best source for policies and procedures that will keep you and your patients safe.